So today I'm going to be talking about kind of the state of advanced care planning as it exists in our country today. I'm going to review specifically our Oregon Advanced Healthcare Directive form. And then I want to talk a little bit about what it means to prepare your surrogate, meaning your surrogate decision maker. And some of this is what we touched upon Professor Torre and I at the last session last month in terms of the importance of conversation and not just filling out the form without any conversation. And then finally, I'll be talking about how there's a movement to really encourage folks not just to think about advanced care planning solely from the side of medical care and the Advanced Healthcare Directive, but to think more comprehensively about it, which is something that we'll pick up in the next session in June. Go ahead and advance. So actually, I'm going to go ahead and skip the poll, if that's okay, Holly. So for those of you who have done an Advanced Healthcare Directive, and I don't know if folks want to answer this or not, but you can do the poll. Basically, did you discuss your healthcare wishes and your goals with the person that you designated to be your surrogate decision maker when you filled out your form? A lot of yeses. We have a very savvy crowd. Okay, next slide. So in 2014, the Institute of Medicine issued this report. It was called Dying in America. And in this report, they kind of detailed the current state of advanced care planning in the United States. Go ahead and click. So what they found was that in general, advanced care planning in the US is very reactive, meaning people don't tend to do it until someone gets sick or something happens to health as a prompt to do it. It tends to be very fragmented, meaning that people fill out these forms and it becomes very form focused, and it's less about the conversation and really any discussion about what the content is about what someone wants. Go ahead and click ahead. So the communication across between patients, individuals, and the people that they're designating to make decisions for them tends to be poor or non-existent at all. And as a result, that the care that individuals receive is often not the care that they desired. And the overall process of how people should approach advanced care planning has been very poorly defined, not just in the healthcare field, but kind of in general in terms of how we approach advanced care planning across the board. So go ahead and advance. This is an example of the Oregon Advanced Directive. And for those of you who are not aware, advanced directives are actually codified by law in every state. So every state has a different advanced care directive sort of statute. In Oregon, our document, go ahead and advance, is designed to be a legal document that allows you as a person to express your wishes for end-of-life care. And advanced directives are important for any adult, from age 20 on until they're of older age, as long as they have the cognitive capacity to make their own decisions. So this is in contrast to the PULST form, which you'll hear about from Dr. Toll, which is a medical order and designed specifically for people who have advanced illness. So the advanced directive, again, is really for any adult, regardless of your health condition. And the only restrictive factor with the Oregon Advanced Directive and most advanced directives is identified by that term advance, meaning that you have to have cognitive capacity to be making your own decisions right now in the here and now when you complete the advanced directive, because you are giving advance notice and advance guidance to your decision makers for the future. So for individuals who have already lost their cognitive capacity to make decisions in the here and now, and who cannot understand sort of the power of an advance directive and granting someone the right to make medical decisions over their own body and their healthcare, the advance directive is actually no longer a possible document for them. Go ahead and click forward. Oh, sorry, I forgot to say on the last slide, sorry, Holly, go back one more slide. That, as I said here, the advance directive, it only pertains to healthcare decisions. So it has absolutely no effect on a person's financial affairs or even their medical insurance. Okay, go ahead. So in some states, an individual may use any variety of advance directives. They may even create one, like taking it off the web. Hold off, Holly. But in Oregon, we only have one version, and the language is dictated by Oregon statute, as I mentioned. So there are some really useful things about the Oregon Advance Directive. For instance, it prompts conversations about a person's views on prolonging life in very specific hypothetical situations. So it talks about CPR and breathing machines. Click ahead. It talks about artificial nutrition, which used to be on the post form, but has now been removed from the post form. And then next slide, or next. It also talks about organ donation and whether or not in the event that you died, you would want your organs used for other patients. Next. And it prompts conversations about curative versus palliative care and pain management and symptom management, again, in the event of discrete hypothetical scenarios. So the next component of Oregon's Advance Directive is about identifying a healthcare representative. Go for it. And so again, this is just another example of the Advance Directive. And actually, unfortunately, they've gotten rid of these really nice booklets. So some changes were made to the Oregon Advanced Healthcare Directive in 2019 in the statutes. And if you can go ahead, Holly. So the goal was really that Governor Brown signed into law efforts to simplify the form and to make it more intuitive. The idea was that there would be one discrete section for patients to be able to appoint their healthcare representative. And that is, in some cases, all that a person will do with the Advance Directive. But in other situations, or if you are able to have more conversations and communication with your health surrogate, ideally, you actually complete the second section of the Advance Directive, which is, again, a slew of hypothetical situations, as well as some options to provide free text for what you would want your healthcare decision maker to decide on, given certain healthcare parameters. The form, in order to be valid on a legal standing, has to be notarized, or you have the option to have two witnesses. And by law, the witnesses cannot be individuals who would benefit in some way, say from your death. So people who are beneficiaries of your will. And those restrictions are listed in the Advanced Care Directive. Go ahead. Now, some of you may have seen some things either in the news or perhaps just from Death Cafe discussions about addendums that are being made available across the country. So this one, which I'll describe, is called the Dementia Directive. Go ahead, Holly. And this actually was featured, in media sites all over the country, not just the New York Times, but it's called the Dementia Directive. It actually comes from a physician by the name of Dr. Brock in Washington. And his idea was that the standard Advance Directive doesn't really go far enough and in detail enough to help individuals who have a known diagnosis of dementia to talk about sort of the gradations and the level and intensity of care that they would want as they progress through dementia, knowing that most people, if assuming they're diagnosed in sort of mild, moderate stages, will then become sort of moderate, more advanced, and end stage dementia. And they may have different wishes depending on where they are with dementia, and yet even in earlier or moderate stages, they may not have the same ability to make decisions and will be relying on an advanced directive representative. So that is something that is available at this website. The other thing that has come up, again, more recently, go ahead, Holly, is addressing this question of voluntarily stopping eating and drinking, which is an ethical and legal right that individuals have in this country. Go ahead, Holly. So this, as opposed to what people in Oregon certainly are familiar with death with dignity, VSED, as it is sometimes called, does not require a person to have to talk to anyone. They don't need to talk to a doctor. They don't need permission. They don't need an order. It is something that individuals who have capacity may choose to do, although ideally with the support of healthcare or hospice as appropriate. But because legal and ethical fields have generally stated that this has not been contested at the Supreme Court level and is a right by any individual of capacity, there has come to be efforts to allow individuals to state their wishes to some extent regarding feeding of food and fluid in the case of cognitive incapacity. Go ahead, Holly. So, on my screen, I can't really see it all the way, and click one more time. So the End of Life Choices organization in New York actually went ahead and this is available through their website. They have an addendum for which individuals can specify whether or not and to what level they would want to receive oral food and fluids in the event of dementia, and to allow them to specify at what level of dementia they would want that to take place. Now, this is an area that I think is still under a lot of ethical and legal questioning. VSED in and of its own is considered to be a right that individuals have when they have capacity. But I think that it's yet to be seen whether or not these types of advanced directive addendums specifying what someone would want in terms of feeding and fluids down the line, that these could potentially be contested, in particular in situations where someone, for instance, lives in a long-term care facility or a nursing facility and requires other individuals who normally would feed and provide fluids to that person to withhold it on their directive. Next slide. So in terms of the Advanced Healthcare Directive, again, one of the biggest pieces that is most important with it is allowing a person to identify a surrogate to make decisions on their behalf when they lose capacity to do so. So in identifying your surrogate, I think very commonly, especially for instance, for partnered couples, one part of the couple will identify, the second half of their couple to be their surrogate. And I want to kind of give more broad recommendations in terms of factors to consider as you think about who you would want to be your healthcare surrogate. Because in some cases, it's not always going to be your spouse, your partner, your adult child. You want to know, and think about, of all the people in your life, who knows you well and who has a, quote, good head on their shoulder. By that, I mean, I have taken care of many patients who chose their spouse to be their healthcare decision maker or chose an adult child. But if that individual has experiences a lot of depression or anxiety or gets overwhelmed by big decisions, perhaps feels a lot of guilt or has difficulty separating what they want for themselves from what you as an individual want for yourself, then you may want to reconsider whether that person is the best person to choose as your healthcare decision maker. Go ahead. So, with respect to, that ability to make decisions, the person that you are identifying as your healthcare decision maker is really meant to step into your shoes and, in the best case possible, to pretend that they are you and make a healthcare decision based on what you think, what they think you would want. And hopefully you've had conversations and discussions about sort of your goals and your wishes and the kinds of outcomes that you would want for any intervention that you have. And so you want someone who can really kind of respect your wishes, regardless of what they might personally feel, especially if there might be conflict about wishes that you may have down the line with what you want for your care and your body. Next. The person that you choose ideally should be someone who can communicate well. So I'm often asked, should I pick someone who's local, who lives near me, or can I pick, my family member who lives, in another state? And I think that really depends. I don't think that a healthcare decision maker has to live in your town or your state. Certainly that helps, but ideally it's someone who can be accessible and communicate well, who is ready to receive the information and recommendations of your healthcare providers in the event that something happens, and to be able to take that information, digest it, reflect on your own wishes that you have shared with that person, and to come up with a decision based on all of those inputs. Next. And then, as I mentioned at the beginning of this slide, you want someone who can be open to potentially very emotional, difficult questions. So, while healthcare decisions can run the full gamut, everything from what medications to take to, whether you're going to sign up for physical therapy in the event of a stroke, they can, of course, also run to the end of life spectrum, which is if you were intubated, if you're on a mechanical ventilator and things are not going well in terms of your healthcare status, would you want them to talk to your physicians to stop ventilator support and switch to comfort care? So these are some of the big decisions that someone may need to make. Do they have you do surgery if you break your hip? So all of these things can be very emotionally difficult. So having someone who is capable of making those types of big decisions and ideally, hopefully prepping them ahead of time with your goals will go a long way. Next. Okay. So how do you prepare for your care in the context of an advanced healthcare directive? Communication is the biggest piece. Again, I'm going to just repeat it over and over again, even though we said it several times during the April session. Think about the Advanced Healthcare Directive not as a one and done form. You completed it and you're done with it. It's really a Cliff Notes version of all of this ongoing conversation that you have with your selected decision maker. So always approach from the focus of communication. Really, the forms are kind of like the icing on the cake. It helps to codify what you're wanting. But again, the drawback of the Advanced Healthcare Directive, for those of you who have completed it, is that the hypothetical scenarios that they give are a few very discrete scenarios. You may never actually fall into one of those scenarios. So it's really more about preparing your decision maker for any decision that they might have to make on your behalf. So what we call surrogate preparation. Next. In terms of the communication, again, is what Professor Teray and I talked about last session is, it's helpful to focus more on what your goals of care are and your values, rather than specific treatment choices. So, of course, there are certain things that people may have kind of a firm line about. Someone may have a firm line that they never want to have a mechanical ventilator. They do not want to be intubated. So of course, that's something that you want to be very clear about. But because again, you will never know all of the potential scenarios that you may come upon with your health, it's more important for your healthcare decision maker to know for any intervention that comes down the road and that you are faced with, what's the goal that you want from that intervention? What is the outcome that you want? Is your outcome to prolong your life expectancy as long as possible? Is your goal to focus on comfort? Is your goal to focus on staying functional as possible? Some medical interventions can do one thing, but at the cost of another. Some interventions can do perhaps both life prolongation and function. But there will come choices in what the even advancements in medical care can provide. And so knowing what someone wants as an outcome from whatever intervention you are going to have to choose between can help your surrogate decision maker know what questions to ask of the healthcare providers and then how to make a choice. Next. So the other things that are important to consider are, all of the sort of other factors, not just medical. So cultural, spiritual values, as well as socioeconomic determinants of health. And I'll explain this in the subsequent slides. Next, okay. So this is a slide and diagram that I know I've shown at a number of our talks, but what it shows is basically the life trajectory of kind of a number of different patterns of different life trajectories for different types of health conditions. So the red is a standard cancer trajectory. The blue might be organ failure like chronic obstructive lung disease or heart failure. The green may be kind of this progressive declining dementia trajectory. And so the vertical axis is function, time is on the horizontal axis. And what you can see is that for all of these trajectories, although at different points, function declines over time. And the point of this slide is really to say that most, with the exception of individuals who some would say are lucky enough to experience sudden death, or perhaps a very rapid cancer progression, most individuals will experience a period of functional impairment from a chronic illness or dementia before they die. And this period of disability can last for years for some individuals. Next slide. So, we know that we have amazing medical advancements that have really changed the field of healthcare. And as we have improved lifespan, although certainly COVID has really drastically changed that in the last couple of years, what we see is that we have an increasing population of individuals who live with disability. And as well, because dementia increases with age, we also have an increasing population affected by dementia. And in particular for dementia or illnesses such as stroke or Parkinson's, the Advanced Healthcare Directive is particularly critical because it allows an individual long before they lose their capacity to preserve their ability to have some say in the care that they receive. Based on what their health surrogates have been informed of. Next slide. So, does traditional advanced care planning miss the big picture? Next. So, given that many of us are not only going to be faced with just an end of life decision, we have to think about how to plan for decisions during incapacity, because that may occur well before end of life. Next. And decisions can run the full gamut. So it's not just about surgery or medications or signing on to hospice. It can include all of these other factors: personal care, long-term care, the socioeconomic context really matters. Next. Someone's financial situation may determine, as many of you have experienced and know, what care options are available. Can you afford care in the home? Do you need care in an assisted living facility or a nursing facility? Next. There's so many different pieces to the puzzle that your decision maker may need to make, and some of this is outside of the purview of the Medical Advanced Healthcare Directive. Next. So you want to be thinking about, what are your supports, family, friends, What is a person's spirituality and how important is that to them? What is the cognitive and emotional needs that a person has, even in incapacity? And what are the work and volunteer opportunities to help support the individual to reach the goals that they want? Next. Go ahead. So this is a table that that I have shared along with my colleagues. I've worked very closely with a couple of attorneys from UC Hastings in San Francisco on medical legal issues. And so what we have sort of distinguished is what in the left column, current advanced care planning. This is sort of the traditional advanced care planning route that doctors advise their patients to do. You go into the hospital, you're sick, they tell you to do an advanced healthcare directive. What we are really promoting on the medical legal side is what we call comprehensive advanced care planning on the right. And some of this will be addressed again in June during the June session of our Illuminating series. Next. So what you can see is that the big difference between just doing an advanced healthcare directive is to reflect on all of the other advanced planning factors that you need to take care of. Again, because when you are living with incapacity or frailty or functional impairments, it's not just the medical decisions that you may need help with. You may need assistance with legal, financial, and your psychosocial environment in order to survive and to have quality of life. Next. Long-term care is a big issue. So while the advanced directive document, not only Oregon's, but most states tend to focus on specific end-of-life hypothetical scenarios, you know, let's say you have a terminal condition, let's say you're in a permanently vegetative state, et cetera, et cetera. What we are promoting is to think about not just, again, the end of life issue, which is, you know, the very end of life, but all of the long-term care lead up to end of life. So if you have dementia, if you have congestive heart failure, and you are needing more assistance with your care, what are the long-term care issues that you need to plan for? Next. And to really think about kind of what your goals are across the spectrum. What I appreciate about the Dementia Directive out of Washington is that it takes dementia as one example and recognizes that, you know, a person's condition with dementia changes over time. They may have more decision making capacity early on and less later. And so this allows your surrogate decision makers to think more broadly about kind of the variation of what you would want. Next. So, you know, your surrogates, not just your medical ones, have to integrate multiple factors to optimize your quality of life. Next. Again, so thinking about not just medical decisions, but how to manage your functional status, your financial situation, where you live, what kind of care you get, and what social contacts and social supports you need. So, you know, as a quick summary, you know, planning for your future, advanced planning, again, the whole goal is to happen before you lose your capacity. And you want to think about not only an advanced healthcare directive, but as will be discussed next month, you want to think about power of attorney, perhaps a trust, and when you get to advanced stages, as Susan will describe next, a post form. Thank you.
Thanks, Helen. Let me get Susan up here. All right. Great, we can see your screen. All right, go ahead.
Hello, it's wonderful to be here. It brings back so many memories of being with Lumina Hospice as the last major presentation I gave before Stay Home, Stay Safe in March of 2020. It feels like coming back full circle. But let's talk about the right time for POLST, because there are some misunderstandings about when is the right time. A quick disclosure that the Center for Ethics does not accept gifts from healthcare industry sources. So if more people fill out a post form, I don't make more money and the center doesn't. And if people fill it out to set limits versus more treatment, financially, it does not make a difference to us. Who is POST for? POST is not for healthy people. POST is for people with serious illness or who are old and frail, and people who want to set limits, because the default in medicine is to do everything. So if you don't have a post form and EMS is called, they will provide all available treatments. And you don't actually need a post form to ask for that. It's for people with advanced cancer. It's for people with advanced heart disease. It's for people with advanced dementia. It's for people with other aspects of advanced frailty. They may have multiple organ systems that are slowing down, but one isn't far in advance of the others. Oregon has the most advanced POST program in the United States. POST was developed here in the early 1990s. This is a look at death certificates from 2015 through 2016, 2 calendar years, and matched with forms in the POST registry. During that period of time, the numbers are slightly higher now. We can see that about half of patients with cancer have a POST form in the registry. Some forms never get entered in the registry, so the number is actually higher who actually have a form. And the most common reason to have a POST form, the highest number, is cancer. Heart disease is next, but not quite as high a percentage. Dementia as the cause of death on the death certificate is next, most common, and almost 2/3 of people with dementia who die in Oregon have a POST form at the time of death. Then we can see chronic lung disease, cerebrovascular disease, diabetes, liver disease. And you'll notice that with liver disease, use of POST is not very common. So there is significant variability by cause of death. Parkinson's, the rate is again very high. The longer people have time to plan and the more they believe that their illness is life-limiting, the more likely they are to have a POST form. We took this same study and looked at how old were people at the time of death if they had a POST form. And we can see that the blue color is that they have orders for do not resuscitate. The orange is that they have orders for CPR. And what we can see is that POST is very heavily used in people. It happens to be the median is 81 years of age. Half of people are 81 or older who die with a POST form. So that it's an older, frail population with advanced health conditions. Let's take a minute because POST has been overly loved. A little is good, a lot is better is actually not right. Who should not be offered a POST form? It won't do them any good, and it's possible that it will cause some harm or confusion, or actually simply short circuit the advanced care planning process with an attitude of, I've taken care of everything, I've completed a form, without conversations and when you're not an appropriate population. This healthy 65-year-old woman had a total hip replacement a few months ago, is back to playing tennis, but spent a short period of time in a rehab facility right after her hip replacement. She was given a post form, full code, full treatment. Did this do her any favors? No, that's the treatment she would have received anyway. Does it potentially do harm? I would argue, yes, it potentially does harm, because all of the records now show she has a post form. And if she gets sicker, it may discourage her primary care provider and others from having a conversation because they think it's already taken place. Also, if she gets a lot sicker, we're so good at finding post forms in Oregon that 6 years from now, when she has metastatic cancer but hasn't completed a new post form, this old post form when she had her hip replacement says she wants full code, full treatment. If she's not well enough to explain she's changed her mind, this can be a real burden for family members. People with physical disabilities, perhaps from an injury, who do not have any life-limiting condition, are not candidates for a post form. They, like other healthy adults, should have an advance directive. This gentleman lives in a group home. He has intellectual disabilities and relatively stable health and is expected to live a number of years. He is not an appropriate candidate for a post form. This is the Oregon post form. This is the 2019 version. And about every 4 years, the Oregon Post Coalition takes a careful look at all of the data that we have about post and makes a decision whether any changes need to be made. The coalition has just voted that in 2023, we will be updating the post form, primarily to add additional protections. Nothing quite as dramatic as the changes we made in 2019, when we changed the name from physician orders to life-sustaining treatment to portable orders for life-sustaining treatment, and when we removed the feeding tube section from the Oregon post form, because EMS never found it to be useful in the field, and you have to have an informed consent process for the surgical placement of a permanent feeding tube. So discussions take place in real time rather than theoretically about something in the future. We will be adding some additional protections in Section C by requiring that this section be completed. You must state who you talk to. About 40% of Oregon post forms are electronic, so that we can put an electronic stop there that doesn't let you proceed unless you state for the healthcare professional to state who was spoken to. But 60% of forms are completed as paper at the present time, inching up a little bit every month toward more electronic forms. Those forms will no longer be entered into the registry if they do not state who was talked to during the process. There are two major sections of the Oregon Pulse Form. The first is about someone who is in full arrest. They are not breathing. They do not have a pulse. Do they want cardiopulmonary resuscitation or do they not? Is obviously what emergency medical personnel want to know immediately at the scene if someone is in full arrest. Most people, we're going to stop here for just 1 second and ask people to enter into the chat. What percent of people with an out of hospital arrest, because POST is an out of hospital order set, to help communicate orders as you move from one setting to another. So an out of hospital arrest, often unwitnessed, what are the odds of successful resuscitation, simply defined as returning spontaneous circulation? Not did you get cognitive function back, not did you survive to hospital discharge, simply could EMS in the field get a return of spontaneous circulation with the CPR. And I have things set up so that I cannot read the chat function.
Okay.
Holly, you want to say a few of the percentages?
Yes. 20%, 60%, 75, 5, 10, 45, 2%.
2% is the closest. Overall, the rate of out of hospital unwitnessed arrest is about 3%. There are conditions where it's even lower. But if you watch television channels, you would think it was 75% because that's the rate of success in most television series like the old ER. So the public generally thinks this works better than it does. And the sicker you are, for example, advanced metastatic cancer, the less likely CPR is going to work because you are dying of your advanced condition and CPR won't fix that. But the public does not know this and often thinks that CPR is likely to be more successful than it is. So I and others who created the Pulse program know that EMS wants this on here, but this isn't where the action is. It will influence how you die, having CPR or not, but probably not in most cases, whether you die, assuming you're a post-appropriate population of advanced illness or frailty. So the action's here because what you mark here has a profound influence on the course of your illness. If you indicate that you would prefer to stay where you are and not be transferred to the hospital unless your comfort cannot be met in your current location, then overall, there's about a 5% chance of dying in the hospital when people mark comfort measures only. Limited treatment is intermediate. You did want to go back to the hospital. That does increase the odds that you will die there. And full treatment, actually in our study, had a higher rate of death in the hospital than people with no pulse at all. And enormously higher was 44% death in the hospital compared to 5% for comfort measures only. So location of death, which influences many things about what your experience is at end of life, is powerfully impacted by Section B, which is the workhorse of the Pulse program. This document was written by colleagues at the next door, which is in Hood River. This was written with a major focus on clear language health literacy to attempt to keep things under 5th grade language and to also make it easy to translate into Spanish, where, for example, the word doctor would include anyone who could sign, even though a range of disciplines can actually sign. Advanced practice nurses and physician assistants are not well represented in many Spanish-speaking countries. So trying to have this be a document that helps someone understand these two documents and why POLST is only for people with serious illness or very old and frail, not for healthy people, that it's a medical order, that it's signed, therefore, by a legally authorized healthcare professional, using the more lay term doctor here, with no disrespect for my colleagues that hold degrees that are NP, PA, and ND. Do you need a lawyer? No. In fact, lawyers can't sign the medical orders. They explain that it will be in the registry, that you keep a copy on the refrigerator, that you would need to go back to your healthcare professional to get it changed. And if you just tore it up, copies are now in the registry, they're in your medical record. You can't just tear it up. It has to be dealt with if you want it revoked or changed. And that it moves across settings of care. This was the hardest part of building the POLST program, is the whole issue around things like admitting privileges, and could emergency department personnel honor a form signed by a health professional that was in a competing healthcare system? And the answer needs to be yes. And we've gotten regs written where the answer is yes. And so that was a very important feature, so that you can look in the electronic database and honor it. You can see it on the refrigerator and honor it, that it moves wherever you move and it still has standing, which is what gives the incredible data in Section B about location of death. And this is where you can see lots more materials in Spanish. Our newest project for the coming year is to create wonderful, simple, straightforward fact sheets in 14 languages by going out with community health workers and figuring out what works for that community beyond the basics of POLST, what is culturally sensitive, how can we make images work for us when people have relatively low health literacy. And there will be new POLST forms. We don't have every single wordage smithing detail worked out, but there will be a revised POLST form in 2023. That does not mean you need to replace everything you have. Old forms are grandfathered. It does mean going forward that there are some advantages to the new form, and when you complete a new form, we would encourage people to use the new form. And I'll stop sharing and say hello to everybody.
Okay, if there's any questions, go ahead and put them in the chat. One question that came up is, this POLST form is clearly an Oregon POLST form. And so, what about other states? Do they all have one?
That is an excellent question. Advanced directives are state specific. POLST forms are state specific. Statute about advanced care planning and who can do what have certain state regulations. Our Oregon POLST registry is funded by the Oregon Health Authority out of the general fund, Oregonians' tax dollars, and therefore is not the United States POLST registry. It's the Oregon POLST registry. But we have reciprocity here in Oregon. And if there's a Washington POLST form, Idaho POLST form, California POLST form, there has been no trouble in honoring them. There may be trouble accessing them. We may not easily be able to find them, but if we are able to retrieve them from another health system or someone provides us with a copy, they would be honored here. There are a little bit of sticking points with Oregon going in the other direction. Some states require the patient's signature. We don't have that. But what we have found is it has such enormous moral weight to show what a person wanted that it is almost always honored unless there's family conflict, and then you have a problem anyway. So then you better have an advance directive that says who gets to speak, and hopefully it matches what your wishes were on the POLST form and that your surrogate indeed continues to stand by your wishes.
Great, thanks for explaining that. Couple more questions. I want to be mindful of folks' time.
Holly, can we extend beyond one if I'm able to stay on? And
I'm able to stay another 15 minutes. I was able to make some other arrangements.
Okay, great. Yeah.
Holly, I know there was a question earlier about whether death with dignity can be stated in an advance directive. And currently, because presumably when the advance directive goes into effect and your surrogate decision maker is making decisions on your behalf, you no longer have capacity. Death with dignity is no longer an option for individuals in that situation, because you have to have in time, in the moment capacity to make a decision and verbal request for death with dignity. Mm-hmm. And then someone I can see here, Holly said, if someone has comfort measures only, is the person still transported to the hospital? Susan, do you want to answer that?
I would like to. Yes, we are very clear that there are times where people cannot be managed in their current setting of care. That they have, for example, metastatic cancer to bone and multiple fractures have occurred. They're in terrible pain. They may not be able to get the equipment into the home to manage that level of pain, and they might need to be transferred. There are times where someone will not stop seizing. There are certain situations. If a patient is already enrolled in hospice, the number of times they need to be transferred is less than if they are not enrolled in hospice and you can't get everything to them fast enough and might have to go to the hospital to get things stabilized before the resources could be delivered. So there are times also where family decompensate and where people need to be transferred. So the rate we found of death in the hospital with comfort measures only was 5%. That's not a surprise to me in primary care practice, knowing that some people don't make enough of a plan ahead of time. And refusal is not a plan. Simply saying on a POLST form, I don't want to go to the hospital, and making no other plans for how you will be cared for at the end of life is not a plan, and likely will result in your still ending up in the hospital.
Okay, thank you.
Bill asked if a person has lost capacity after having filled out a POLST years before, can that original form be revoked or replaced? Susan.
You bet. All medical orders can be changed. Let's think for a minute. If I care for a patient with pneumonia and the results come back of the sensitivity tests that the pneumonia is not sensitive to the antibiotics I'm using, I write new orders. If the situation changes with POLST, either you got a whole lot better from the cancer and you want more aggressive treatment, or more likely and more common, your condition declined and the level of treatment you wanted is no longer the level of treatment you want as you're approaching your death. So it's revoked and replaced. It may be that the patient completed the first POLST form and said, do not resuscitate and limited treatment. I want to go back to the hospital. I want the easy things fixed. They get a lot sicker. And the surrogate that they appointed on their advance directive works with the healthcare team to transition the patient to comfort measures, perhaps enroll them in hospice. So it can be that these two documents work exactly hand in hand to transition to a new set of orders. But medical orders can be revoked. And they need to be able to be revoked because the medical situation may change. Your values didn't change, but the backdrop of what those values are operating against changed. And therefore, the orders need to change.
Oh, I was going to ask if Robin was still here and wanted to unmute, but she just put her question in the chat. When the POLST form is updated and available next year, is her previous POLST deleted, updated, or remain in the database along with the new one?
So what happens in the database is, first of all, you don't automatically revoke a POLST form that is perfectly what you want simply because we've created a new version. But should you wish to update your form or write a new one for someone, we would encourage you to use the newest version because there are reasons we've made these changes that offer additional protections and clarity. But let's assume that you had a 2019 POLST form and your wishes are a little bit different now, and it is already 2023 and you're writing a new POLST form using the new one. Automatically, the registry archives your 2019 form, and what is visible and the only thing that emergency medical personnel can see is the new one, the 2023 version. In your electronic medical record at a major health system, what you see is a void, or you can read the old one, but it says voided, and you see the new one. But you can look at the history of someone changing over time, which is often very valuable to those making decisions or talking with family to see what the history has been of changing wishes or values or goals of care. And so that palliative care team, for example, in a hospital incredibly values the ability to see the history of POLST forms and advanced directives if they've been changed.
Thank you. We've had actually a couple people say this. One sent a direct message to me. As a healthy, active 65-year-old, they were offered a POLST at their welcome to Medicare visit. Said no. And so the other question was, you know, is this because they don't have an advanced directive? Can you shed some light on that?
Yes. Remember our dear woman, the tennis player. Healthy, welcome to Medicare, has a line that says advanced care planning. We are doing our best to continue to educate the large number of healthcare professionals in our state, some who have recently moved here from other states, who are not as pulse savvy as if you had, for example, gone to medical school here. And so the Oregon Medical Board helped us by sending out an announcement about why it is not appropriate at Welcome to Medicare to offer a pulsed form. But we still know that it occasionally happens and that people mean well, but that they don't themselves have as good of understanding as people on this listening are carefully ascertaining, and that Helen so clearly articulated about who should have which document, because a healthy 65-year-old should have an advance directive.
Susan, can you answer? Someone asked if a post is redone, does the original assigned number carry over, or is there a new number given?
The number carries over. Forever you are a registrant in the registry, and your registry ID number follows. So we can tell if you got 4 different pulse forms over your lifetime, for example, and helps us with research about improving the quality of pulse forms. But if you have like a magnet on your refrigerator from the registry and you changed pulse forms, that magnet number is still valid.
And then Susan, this comes from Dr. Harris, our hospice medical director. Will the new pulsed have a way to preclude the contradictions in order requests that sometimes we find on Pulse, for instance, attempt CPR, but limited, or comfort measures only? And so.
Yes, is the answer. First of all, 40% of Pulse forms completed in the state, you electronically cannot make the order combination of either comfort measures only or limited treatment and yes to CPR. There's a hard stop in all the electronic systems. So that would include the Samaritan ePulse system. We will write on the new 2023 Pulse form that it is required to put full treatment if you select CPR. That will affect about 4.5% of the Pulse forms going into the Oregon Pulse Registry that are paper and have that order combination. It is too confusing. Until we had more ePulse, we have had trouble controlling this because you put it on your refrigerator, I can't keep it from being there. But we are going to more formally condemn it and move toward more and more ePulse systems that we can actually stop it. Thank you, Dr. Harris. Good to see you.
There was one question that I saw, which is, does the Pulse always trump the advance directive? And again, there are 2 different kinds of documents. So the Pulse is an active medical order. As soon as a provider signs it, it is an active order that paramedics or emergency room personnel have to follow. Whereas the advance directive, again, it's a legal document that simply allows a decision maker to make a decision for you. And ideally, they would be making it in line with what your wishes are. So they can fill out a Pulse form for you. And depending on your healthcare condition, yes, it may seem like what's on the Pulse doesn't necessarily match what's in your advance directive. But again, that comes down to the conversation that you have with your surrogate decision maker. So.
And the document with the most recent date also is given some increased priority.
Yes, thanks.
Great. Well, thanks for answering all those questions. Thanks for the great questions coming in the chat. All right, we'll let everybody go. Thank
you, Susan.
Question. Robin may have a question for us. Let me see. me see if I can find you. Hold on. Should be able to unmute Robin. Oh, here you are. Okay, there you go. You're unmuted, Robin, but we can't hear you.
Robin, if you have a question after this Zoom ends, feel free to reach out to Holly or to our general Lumina line, and we can get an answer to you.
Yeah, sorry about that, Robin. All right.
It is such a pleasure to be part of this wonderful community again. You serve your community so well, you reach out to so many, you provide such valuable education. Please partner in educating the rest of the state so there are fewer healthy 65-year-olds with pulse forms.
Hear, hear. Thanks, Susan.